So hello everyone and welcome to this free webinar. I'm Dr. Muhammad Helmy, the Chief Mentor of Part 1 MRCOG course, and I'm a lecturer and consultant of Obstetrics and Gynecology, and also I'm a consultant of Reproductive Medicine and IVF. I'm glad to have you with me today in this free webinar, and today we are going to talk about the abdominal incisions in obstetrics and gynecology and nerve injuries with gynecological surgeries. Actually, this is a very important topic related to part 1 and also part 2 MRCOG. So both candidates of part 1 and part 2 MRCOG can have benefit from the summary of this topic or this webinar. And the reference of the topics today will be the talks published in 2014, the abdominal incisions and sutures in obstetrics and gynecology, and the other one, which is the nerve injuries associated with the gynecological surgeries. These sutures will be out of the scope of today's webinar. We are going, maybe sometime we can allocate another webinar to talk about the sutures in obstetrics and gynecology, because this is a topic which needs more focus and more concentration. So today we are going to talk only about the abdominal incisions and also the nerve injuries. So let's start with the abdominal incisions. Abdominal incisions used in the gynecological procedures can be divided into transverse or vertical incisions. So broadly, we can classify them into transverse or vertical. Of course, each type of these incisions have advantage and disadvantages. The advantages for the transverse incisions that they have better cosmetic results. They are less painful, less interference with the post-operative respiratory movement, and greater strength. On the other hand, the disadvantages that they are more time consuming, more hemorrhagic. There is some sort of limited ability to explore the abdominal cavity and the divisions of the layers of the abdomen, the fascia, the muscle, the nerves. All this can result in potential spaces which can form hematoma or seroma. So these are the advantages and disadvantages of the transverse incisions. Looking to the vertical incisions, they have some advantages like excellent exposure of the field. By the vertical incision, you can have a good exposure to the abdominal field, and also it's easily extendable. The median incision is least hemorrhagic, minimum nerve damage, and rapid entry to the abdomen and pelvis. On the other hand, the disadvantages can include wound dehiscence and hernia, poor cosmetic result, high infection rate, hemorrhage, and operative time, and this is with the paramedian incisions. So it's important to know the advantages and disadvantages of the transverse and the vertical incisions. Generally speaking, the incidence of significant wound infection is equal to or less than 5% for all abdominal operations, and we can lower the incidence of infection by the preoperative showering with antiseptics. This reduces the infection rate from 2.3% to 1.3%, nearly the half. So we can reduce the rate of the infection to the half by preoperative showering with antiseptic solution. And this is a very important exam question, by the way. Also, the depilatory preparations can lower the wound infection rate versus no hair removal. And the reason for hair removal is to prevent the interference with wound approximation in certain incisions. So also the depilatory preparations before the operation is important to reduce the infection rate. Of course, we should not make the skin incision by the monopolar electrosurgical device. We have to use the scalpel for the incision in the skin. After that, we can use the monopolar in the lower layers for the fat, for the fascia, and so on. We can use the monopolar electrosurgical device, but of course not for the skin. And the same scalpel can also be safely used for superficial and deep incisions. You don't have to change the scalpel. You can use the same one for superficial and deep incisions. I think some of the participants are complaining of the voice. Is my voice clear for now? Can someone reply to me?
Yes, it is clear.
Okay, thank you so much. So please, the backend team, one of the backend team, please contact this colleague who have problem with the voice.
Yes, sure, Dr. Helmy.
Thank you so much. So that was a quick introduction about the abdominal incision. Now let's talk about some specific incisions we use in the gynecological surgeries. And let's start with the Phanen-Steele incision, or the Phanen-Steele incision. Both pronunciation is correct. And this is a curved incision. It's like 10 to 15 centimeter long and 2 centimeters above the pubic symphysis. Here we cut the skin, the rectus sheath, by sharp dissection, and also we will dissect the fascia along the rectus muscles, but without cutting the rectus muscle. So we use the sharp dissection to open the skin, the rectus sheath, but we don't cut the rectus muscles. And we dissect the fascia along the rectus muscle. That's the Phanen-Steele incision. Look here. We cut sharply. It's like a curved incision like that. The skin and up to the rectus sheath. We divide the sheath transversely like that and dissect it from the rectus muscle. Then we retract the recti muscles without cutting them to both sides to reach the peritoneum. Then we divide the peritoneum to reach the abdominal and the pelvic cavity. So that's the Phanen-Steele incision. Another incision called the Cohen incision, and this is a straight transverse incision through the skin, which is 3 centimeters below the level of the anterior superior iliac spine. So it will be higher than the Phanen-Steele incision, as shown in the picture here. Here we open the skin, of course, by our scalpel, then all the layers. After that, we open it by blunt dissection without using the scalpel or the monopolar device. We open the layers after that by blunt dissection. After that, we retract also the recti muscles vertically on both sides and then open the peritoneum. So here in the Cohen, we use blunt dissection in the subcutaneous layers, the fat, the fascia, and also we bluntly separate the recti muscles on both sides and then open the peritoneum. Another incision called the Maillard incision. The Maillard incision is also called the muscle cutting incision. And from its name, we can expect that all layers will be sharply cut, including the muscles or the rectus muscles. So all the layers of the lower abdominal wall will be incised transversely about 3 to 8 centimeters above the symphysis, and then the height of the incision from the symphysis or the distance will depend on the indication of the surgery. So we can go upward up to 8 centimeters if we want to reach like higher distance in the abdominal cavity. The fascia is not dissected free from the rectus muscles. The peritoneum is usually entered in a transverse fashion. So we use the sharp dissection to cut all the layers, including the muscles. That's the Maillard incision. Another incision called the Moschel incision, and it runs in the upper limit of the pubic hair. So it's lower than the Maillard, but it's also a muscle cutting incision. So the Moschel is like the Maillard incision, but it's lower than the Maillard. We do the Moschel incision in the upper limit of the pubic hair. So it will be lower than the Maillard incision, but also the rectus muscles will be cut. The Kästner incision. This is a slightly curved incision beginning below the level of the anterior superior iliac spine, extending just at or just below the pubic hairline. But this incision has, some limitations because it's time consuming. We cannot extend this incision. The extensibility is limited, so it's not used a lot, this Kästner incision. And also we can encounter the superficial branches of the inferior epigastric artery may be cut. So this incision is not popular incision in practice. The Churny incision is a specific incision on the area of the pubic symphysis where we can transect the rectus muscles at their insertion on the pubic symphysis and retract them upward or cephalad to improve exposure. And this kind of incision, the Churny incision, as we can see in the figure here, this is the insertion of the rectus muscle at the symphysis pubis. We cut the rectus muscle at its insertion point and then remove it or move it upward like that to make it feasible to reach the lower regions of the abdominal cavity and the pelvis. And this is important for some procedures related to the urinary incontinence, to reach the space of rectuses, to gain exposure also to the pelvic side wall for hypogastric artery or the internal iliac artery ligation. These are the transverse incisions, but of course, the two most popular of them are the Fannin steel incision and the Jewel Cohen incision. These are the most popular in the transverse incisions for gynecological surgeries. Am I clear so far, guys? Clear so far? Do you have any questions? Shall I proceed? Okay. Yes, okay. Thank you. Okay, so for vertical incisions, it's very well known that we have the midline or the median and we have the paramedian incision. Of course, the midline is the most versatile as it can be easily extended. And of course, we know the midline by the pyramidalis muscle. The paramedian can improve the extensibility if we want to go on either side of the pelvis or the lower abdomen. But generally speaking, there is no difference in wound infection, dehiscence, or respiratory problems with midline and paramedian incisions. For the oblique incisions, we have two oblique incisions can be used in the lower abdomen, very famous, the gridiron muscle splitting incision of McBurney and the Rookie-Davies or the Elliott incisions. The Rookie-Davies incision is a transverse incision, as shown in the picture here, made at the junction of the middle and the lower third of the line joining the anterior superior iliac spine to the umbilicus. So if we have a line joining the anterior superior iliac spine like that, and the umbilicus, this transverse incision is made at a point which join the lower third and the middle third of this line. We make a transverse incision like that, and this is called the Rookie-Davies incision. We have the gridiron incision, which is known in the practice by the McBurney incision, but of course the McBurney is an anatomical point and the incision is called the gridiron incision. Of course, this is done at the McBurney point, an oblique incision done at the McBurney point, in which the incision is done through the skin, the subcutaneous fat, to the abdominal wall muscles, which is split along the direction of their fibers. So in the gridiron incision of McBurney, we cut all the layers, the skin, the fascia, the muscle fibers will be also cut along their fibers, the external oblique, the internal, the transversus abdominis muscle, until reaching the parietal peritoneum. So what are the incisions used for cesarean section? And of course, this is well known for all of the colleagues who practice Obs and Gynae for years now. And of course, we use the Joel Cohen and the Fannin style incisions. And when we compare both incisions, we will find that the Joel Cohen has less post-operative febrile morbidity, less analgesia requirements, shorter operating time, less intraoperative blood loss and adhesion formation, reduction in the hospital stay, and in-wound infection. So Joel Cohen is preferable than the Fannin style incision for cesarean section. But of course, the use or the decision to choose one of them will depend on the case, on the past history of this case. Maybe this is a previous a woman with previous multiple cesarean sections. You need to make sharp dissection, so you may have to use the Fannin style incision because it will be wider than the Joel Cohen. You are going to use sharp dissection. It will be more appropriate for such case than like doing a cesarean section for a primigravida, for example. So of course, the choice of the incision will depend on the individual case, but generally speaking, the Joel Cohen will be preferable than the Fannin style incision. So this was a quick notes about the abdominal incisions, the transverse, the vertical, and the oblique incisions, which maybe have benefits or use in our specialty. Now let's go for the nerve injuries. Now let's talk about the nerve injuries associated with the gynecological. Of course, the iatrogenic nerve injury following surgery is a significant cause of post-operative neuropathy. And the patient malpositioning, improper incision sites, and the self-retaining retractors are the major contributors to the origins of intraoperative gynecological nerve injury. So these are the three main causes of nerve injuries during the surgery: the patient malpositioning, the improper incision site, and the self-retaining retractors. The incidence of neuropathy following gynecological surgery is between 1.1 and 1.9%. Most of them, fortunately, have a good prognosis with minimal or no intervention necessary for resolution of this neurological impairment. And this is about that the prognosis is good in the majority of cases. Talking about the pathophysiology of the nerve injury. Neuropathy usually results from a disruption to the blood supply of the nerve caused by the injury. And we have three types of nerve injury. We have the neuropraxia, and here we have external nerve compression only. There is external nerve compression, which makes some disruption of the conduction of the impulse along some or part of the axon. So this is the mild form, and the recovery will be within weeks, maximum few months, and complete recovery will occur. That's called the neuropraxia. We have the axonotemesis. Here we have severe compression with axon damage, but with preservation of the Schwann cells in the axon. The Schwann cells, of course, is the glial cells surrounding the axon and responsible for the myelin formation. These cells will be preserved in the axonotemesis, so regeneration can occur, but recovery will take longer time, several months maybe. The severe form is the neurotemesis, where the nerve is completely transected with damage to Schwann cells. This has a poor prognosis, and usually recovery will not occur unless restorative surgery is done. So this kind of injury, the neurotemesis, needs reconstructive surgery. The mechanism of nerve injury involves a combination of compression, stretch, entrapment, and transection. So the nerve may be compressed, may be stretched, may be entrapped in sutures, or may be completely transected by the scalpel or the monopolar surgery, monopolar device or so. So this is the four mechanisms by which the nerve is injured. The compression and stretch injuries are typically caused by improper placement of the self-retaining retractors, such as the Palfor or the Pook-Walter retractors. This is the Palfor and this is the Pook-Walter retractor. These are self-retaining retractors. You don't have to hold them during the surgery. You put them in a certain way, fix them, and they will open the field without need to hold them or to remove them from time to time during the surgery. So prolonged use of these self-retaining retractors, especially if they are improperly placed, this can cause nerve compression and stretch. Of course, transection injuries are related to the cited surgical incisions. Please, can you turn off your mics? Except if you are going to ask a question. The Fannin style and low transverse incisions are the most common incisions performed in gynecology. When these incisions extend beyond the lateral margin of the inferior rectus abdominis muscle, the lateral cutaneous branches of the iliohypogastric and the ilioinguinal nerves are liable to be injured. So we have to be careful when doing the Joule-Cohen or the Fannin style incision not to extend beyond the lateral margin of the inferior rectus abdominis muscle, because this can cause injury to the iliohypogastric and ilioinguinal nerves. Study found that the abdominal wall incisions below the level of the anterior superior iliac spine, approximately 5 centimeters superior to the pubic symphysis, had the greatest potential for injuring the ilioinguinal or iliohypogastric nerves. So again, we have to be careful when doing the low transverse incisions not to extend beyond the level of the lateral margin of the rectus abdominis muscle, because this can include the ilioinguinal or the iliohypogastric nerves. The entrapment nerve injuries, usually during the reconstruction or during the suture, and this can cause pain after the nerve entrapment, in contrast to loss of function and numbness that occurs with nerve transection. So usually the nerve entrapment will cause pain after the operation, while the nerve transection will cause loss of function and numbness by or in the areas supplied by that nerve. So these are the mechanisms of nerve injury. And also the chronic nerve-related pain was seen in 7% of women following Fannin-style incisions, and this was attributed to the entrapment of the ilioinguinal and iliohypogastric nerves. So when we extend the incision in the and then doing the sutures, sometimes we entrap the ilioinguinal and iliohypogastric nerves during the sutures. This can cause post-operative chronic nerve pain, and this is seen in 7% of women following the Fannin-style incision or the Fannin-steel incision. Although rare, the other sources of perioperative lumbosacral nerve injury can be or can happen after regional anesthesia, like dural or spinal, because of the needle or the catheter tip trauma to the nerve roots and the spinal cord, or injection of the anesthetic into the wrong spinal compartment. And most often, the neurological damage secondary to the regional anesthesia is apparent immediately during the procedure. So this kind of nerve injury due to regional anesthesia, although rare, but they cause immediate manifestations in the patient. And again, they can be occurred due to the needle or the catheter trip trauma to the nerve root or the spinal cord, or injection of the anesthetic into the wrong spinal compartment. So guys, am I clear so far? Do you have any comments or questions for now? You can reply using your mics, or you can write in the chat. Do you have any question?
Okay.
Okay.
No question.
Okay, thank you. Okay, let's now move to talk about some specific nerves, which are very important to know. And there are many questions in the exam in part 1 and also in part 2 related to these injuries or these common nerve injuries in gynecological surgeries. Now let's talk about the most important of them is the femoral nerve, And gynecological surgery is the most common contributor to iatrogenic femoral nerve injury. And of course, abdominal hysterectomy is the most responsible operation for this injury. And of all reports of gynecological associated neuropathy, the femoral nerve is most frequently implicated, and the incidence is at least 11%. This is a very important and very frequent exam question in part 1 and also in part 2 MRCOG, that the femoral nerve is most frequently implicated in gynecological associated neuropathy. When we talk about the anatomy of the femoral nerve originates from the nerve roots of L2 to L4, and this is a very important point or information regarding anatomy of part 1 MRCOG. Then it passes infralaterally through the psoas muscles. This is the psoas muscle. It passes infralaterally and emerges from its lateral border as shown in the figure here, and exits the pelvis beneath the inguinal ligament lateral to the femoral vessels to enter the thigh. So that's the anatomy of the femoral nerve. So does anyone know what is the sensory and motor functions of the femoral nerve? Can anyone answer? if we know the function of the nerve, we can know what will happen if this nerve is injured. So the femoral nerve supplies the anterior medial thigh and the medial aspect of the calf muscles. It also, the motor functions are hip flexion, knee extension, and hip adduction. So hip flexion and adduction and knee extension. So this is the movement we usually do during climbing the stairs. We do hip flexion and adduction, then knee extension. By this we climb the stairs. So when we know the sensory and the motor function of the nerve, we can then expect what will happen if this nerve is injured. Before knowing what will be the symptoms of femoral nerve injury, let's know what is the most common cause of femoral nerve injury. Actually, femoral neuropathy commonly occur as a result of compression of the nerve against the pelvic side wall. This happens when excessively deep retractor blades are used or during the lateral placement of retractors. And in one study, the incidence of the femoral neuropathy when self-retaining retractors were used during gynecological surgery was 8%, compared to the incidence of less than 1% when not used. So by this information, we can also expect what to say when we are asked about how to prevent nerve injury. So the first thing is to minimize the use of these self-retaining retractors. And if we are going to use retractors, we can use the handheld retractors. Why? Because when you, in the surgery, hold the retractor by your hands, you can, from time to time, remove the retractor and replace it again. So you avoid prolonged compression of the nerve, especially in those surgeries taking long times. So when you hold the retractor by your hand, you put it in the place you want, then after like few minutes or half an hour, you can remove this retractor and put it again. So the on and off placement of this retractor will avoid the prolonged compression of the nerve. But the self-retaining retractors, yes, it's easier for the surgeon to put the retractor to expose the field, but of course the prolonged duration will cause nerve compression. Also, the inappropriate patient positioning in the lithotomy position can cause stretch-related femoral neuropathy. Because sometimes the patient is put in exaggerated lithotomy position. There is hyperflexion, abduction, and external rotation of the hip like that, resulting in kinking of the femoral nerve under the inguinal ligament, especially if the surgeon is doing like a vaginal operation and it was a lengthy operation. The prolonged lithotomy position in that way can result in stretch-related femoral neuropathy. So these are the most common mechanisms by which the femoral nerve is injured. And as we mentioned, the sensory and the motor function of the femoral nerve. So there will be weakness of hip flexion and adduction and knee extension. So there is inability to climb the stairs. This is a very important and very frequently repeated exam question in part 1 and also part 2 MRCOG. Also, there is loss of the knee-jerk reflex, paresthesia over the anterior medial thigh, as well as the medial aspect of the calf. So there will be motor and sensory dysfunction after femoral nerve injury. Is it clear? Okay, thank you. The second nerve or nerves will be the ilioinguinal and iliohypogastric nerves, and both of them originate from T12L1 nerve roots. And both nerves pass laterally through the head of the psoas muscle. Then, this is the head of the psoas muscle. Both nerves will run diagonally like that along the quadratus lumborum muscle, which is shown by the pointer here. That's the quadratus lumborum muscle. After that, the iliohypogastric nerve will pierce the external oblique aponeurosis, while the ilioinguinal nerve will pass through the superficial inguinal ring into the inguinal canal. Both nerves have sensory functions only. And the iliohypogastric nerve provides sensation to the skin of the gluteal and the hypogastric region, while the ilioinguinal nerve provides sensory innervation to the skin overlying the groin, inner thigh, and labia majora. So both of them have sensory functions only. And of course, we can expect that the injury of each of these nerves will cause sensory impairment only. Injury to these nerves can be seen typically in suture entrapment at the lateral borders of flow transverse or the phalansteal incisions, as mentioned before. And the incidence of their injury following a phalansteal incision is about 3.7%. There is a diagnostic triad of the injury, which is called the diagnostic triad of the ilioinguinal iliohypogastric nerve entrapment syndrome. And the patient can have sharp burning pain radiating from the incision site to the mons pubis, labia, and the thigh. There is paresthesia over the nerve distribution areas and pain relief following administration of local anesthetic. So the patient will complain of sharp burning pain from the incision site to the area of the mons pubis, labia, and the inner thighs, with paresthesia over the nerve distribution areas. And when the patient is having like local anesthetic injected into the nerve areas, the pain will be relieved. This triad can diagnose ilioinguinal and iliohypogastric nerve entrapment. The third nerve will be the genitofemoral nerve, which originates from L1, L2. And of course, the origins of these nerves is very important for the candidates of Part 1 MRCOG in the anatomy section. And this nerve transverses the anterior surface of the psoas muscle, lying immediately lateral to the external iliac vessel. And this is a very important anatomical point, because we are going to know that when we remove the external iliac lymph nodes during the lymphadenectomy, we can injure the genitofemoral nerve. The genitofemoral nerve, as shown in the figure here, this is the genitofemoral, which transverses the psoas muscle, lying immediately lateral to the external iliac vessels, will give a femoral branch, which passes to the thigh beneath the inguinal ligament, and also will give a genital branch which enters the deep inguinal ring. So we have the femoral branch, like the femoral nerve, will go to the thigh and beneath the inguinal ligament, while the genital branch will go through the deep inguinal ring. This nerve is susceptible to injury during pelvic sidewall surgery and during removal of the external iliac nodes. And the genitofemoral nerve injury results in paresthesia over the mons pubis, labia majora, and the femoral triangle. This nerve is also having only sensory function without motor function, so its injury will result in paresthesia over the mons pubis, labia majora, and the femoral triangle. The electrocutinous nerve of the thigh, it's also a sensory nerve emerging from L2 to L3, and it emerges from the lateral border of the psoas muscle. That's the lateral border of the psoas muscle. It emerges from the lateral border of this muscle and pass anterior to the iliacus muscle and enter the thigh, also posterior to the inguinal ligament, or posterior to the lateral part of the inguinal ligament. That's the lateral cutaneous nerve of the thigh. The mechanism of the injury of this nerve is similar to the femoral injury. So it can be injured also by using the deep self-retaining retractors or during the lithotomy position by stretching beneath the inguinal ligament. And the symptoms will include paresthesia and pain in the anterior and posterolateral thigh, and this is called myalgia paresthesia. Myalgia paresthesia. This is the paresthesia related to the injury of the lateral cutaneous nerve of the thigh. The next nerve is the Obturator nerve, which emerges from branches of L2 to L4, and it converges behind the psoas muscle. The nerve passes behind the psoas muscle, and here that's the Obturator nerve. It passes behind the psoas muscle and passes over the pelvic brim in front of the sacroiliac joint and behind the common iliac vessels to enter the thigh via the obturator foramen. So it passes behind the psoas muscle and then come to the pelvic brim, anterior to the sacroiliac joint, entering the thigh through the obturator foramen. So we can expect that any intervention near the obturator foramen can cause injury to the obturator nerve. So this nerve is most frequently injured. During the retroperitoneal surgeries, incision of endometriosis, especially if there is deep infiltrating endometriosis, passage of a trocar through the obturator foramen, insertion of the transobturator tapes, and during the paravaginal defect repairs. So the injury of the obturator nerve is very commonly seen in the urogynecological surgeries, like the TOT, for example, the transobturator tape. And the obturator neuropathy will present with sensory loss in the upper medial thigh and motor weakness in the hip adductors, because it supplies the hip adductors and the upper medial thigh. That's the sensory and the motor functions of the obturator nerve. So of course, any injury to the obturator nerve will cause sensory loss in the upper medial thigh and motor weakness in the hip adductors. The sciatic and the common peroneal nerve. The sciatic nerve arises from L4 to S3 nerve roots, emerges from the pelvis below the piriformis muscle. That's the piriformis muscle. It emerges below this muscle and curve in the gluteal region, lying between or midway between the posterior superior iliac spine and the ischial tuberosity, and in the thigh between the greater trochanter and the ischial tuberosity. The sciatic nerve gives or terminated by giving the common peroneal and the tibial nerves at the mid-thigh. And a very important anatomical point related to the common peroneal nerve, that it winds forward or winds forward around the neck of the fibula. It's around the neck of the fibula region here, as shown in the. So of course, any injury at that site can affect the common peroneal nerve. Both nerves, the sciatic and common peroneal nerve, are susceptible to stretch injuries from the hyperflexion of the thighs in the improper lithotomy position. Also, the common peroneal nerve can be compressed at the fibular neck in lithotomy. As we can see here, the compression of the common peroneal nerve at the fibular neck site in the lithotomy position can cause injury of that nerve. So it's very important to put something like soft pad between the stirrups here and the neck, or the knee of the patient, or the neck of the fibula. So this is very important because this prolonged lithotomy position can cause injury to the common peroneal nerve, and of course the hyperflexion can also cause injury to the sciatic nerve. The sciatic nerve injury presents as sensory impairment below the knee and weakness of hip extension and knee flexion. So the sciatic cause hip extension and knee flexion, while the femoral nerve cause hip flexion and knee extension. So they are against each other, the sciatic and the femoral nerve. So sciatic nerve injury will cause weakness of hip extension and knee flexion, and a very famous phenomenon which occurs after the injury of the common peroneal nerve is the foot drop, is reported when the common peroneal nerve is injured. Because the common peroneal nerve cause dorsiflexion and eversion of the foot. So injury of the common peroneal nerve will cause foot drop like that. So this is a very important point, a very important exam question. The foot drop is reported when the common peroneal nerve is injured. Also, plus that we have paresthesia over the cuff and the dorsum of the foot, because also the common peroneal has both motor and sensory functions. Am I clear so far? Okay, very good. The pudendal nerve is a nerve originating from S2 to S4. The nerve exits the pelvis through the greater sciatic foramen below the piriformis muscle, like that, and it runs behind the lateral third of the sacrospinous ligament and the ischial spine, then re-enter the pelvis again through the lesser sciatic foramen to the pudendal or the Alcock's canal, the pudendal canal or the Alcock's canal, which is a canal formed by the fascia of the obturator internus muscle, which carries the pudendal nerve and the internal pudendal vessels, the artery and the vein in that canal. So it exits the pelvis through the greater sciatic foramen below the piriformis muscle, then runs behind the sacrospinous ligament and enters the pelvis again through the lesser sciatic foramen. The nerve is susceptible to entrapment injuries during the sacrospinous ligament fixation, one of the operations done for the prolapse. So during the sacrospinous ligament fixation, we can injure the pudendal nerve. And the patient will report post-operative gluteal, perineal, and vulval pain, because the pudendal nerve supply the gluteal region, the perineum, and also part of the vulva and the labia. So this can cause female sexual dysfunction due to the pain caused by this nerve entrapment. So this table is a summary of all above mentioned nerves. So you can look at the table to summarize all these nerves: femoral, obturator, sciatic, the iliohypogastric, ilioinguinal, pudendal, the lateral cutaneous, and the genitofemoral, the origin of each nerve, the sensory and the motor functions, and the clinical presentation. Two very famous questions in the exam about the femoral nerve: the inability or the inability to climb the stairs, and the foot drop of the common peroneal nerve. Regarding the brachial plexus, it also can be involved in the surgeries, in our gynecological surgeries, and this is due to the improper positioning of the arm of the patient during the surgery. We have the stretch injuries, which is a very common mechanism of injury to the brachial plexus. The brachial plexus originates from the roots C5 to T1, supplying the upper limb, and it lies within the posterior triangle of the neck. The first mechanism of injury to the brachial plexus is the hyperabduction of the arm, like that during the surgery, when the arm boards, this is the arm board, are extended beyond 90 degrees from the long axis of the operating table, or when accidentally the arm fall from the board during the procedure. So we have to be careful to place these arm boards in a good position, not exceeding 90 degrees, and to fix the arm of the patient well to avoid the accidental fall of this arm or the shoulder during the operation. The hyperabduction can cause lesions in the upper nerve roots, the C6, C5 and C6 of the brachial plexus. The injury of the upper roots will lead to what's called Erb's palsy, or the waiter's tip deformity. The shoulder will be medially rotated and abducted, the arm extended, the forearm pronated, and the wrist flexed like that. Erb's palsy, or the waiter's tip deformity. Another mechanism of injury of the brachial plexus, when we use shoulder braces. These shoulder braces, which can provide support to the shoulder during the steep Trendelenburg position, especially during the laparoscopic surgeries, because we need to put the patient in that steep Trendelenburg position to move the intestine away from the pelvis like that. So we put the patient in this position, and to prevent the fall of the shoulders or their movement, we put shoulder braces to make like some downward traction on the shoulder to stabilize them. But this can cause injury to the lower roots of the brachial plexus, C8 to T1. And this can result in what's called the Klumpig's palsy, with loss of function of the small muscles of the hand. The patient will be presented by claw hand. The forearm will be supinated, the wrist extended, and the fingers are flexed like shown in the Klumpig's palsy or the claw hand. So these are the different types of nerve injuries. So how to treat nerve injuries? If nerve injury occur, how to treat them? As I said at the introduction of this session, that fortunately most neuropathies will resolve spontaneously within minimal intervention. Sensory neuropathies will typically resolve within 5 days, whether motor deficits may take up to 10 weeks to recover. And occasionally, some neuropathies can persist beyond 1 year. Detailed neurological examination and, of course, EMG studies are very important to diagnose the neurologic deficit. And, of course, if we diagnose any neurologic deficit, and as obstetricians and gynecologists, we have to refer the case immediately to a neurologist. Some painful neuropathies can respond to pharmacological agents like tricyclic antidepressants and the GABA antagonist. These pharmacological agents can be used in the treatment of neurogenic pain. But if the neuropathy failed to resolve after 6 months of the pharmacological agents, in such cases, we can do local nerve blockage or even surgical excision of that nerve, especially if the nerve is having, of course, only sensory function, because this pain can interfere with the quality of life, or we can inject like local anesthetic or cause decompression. So all these are maneuvers which can be done if pharmacological agents fail to resolve the neuropathy within 6 months. Motor impairment from retraction or stretch-related injury can be managed by physiotherapy. And also the active use of the affected muscles is generally recommended, although in some cases we can do splinting to guard against further injury. So this will depend upon the case. Some cases will respond to physiotherapy and active use of the muscles. Some other cases may need some splinting and limitation of movement until the the injury regenerate or the nerve regenerate to avoid further injury. And of course, also this will depend upon the clinical examination and the EMG. Nerve lesions that do not heal are often the result of complete nerve transection. And of course, if there is complete nerve transection, we have to refer the case for reconstructive surgeries using microsurgical techniques. One of the promising surgeries is the repair of transected obturator nerve, which show excellent prognosis and complete motor recovery after physiotherapy. So these are the treatment modalities of nerve injuries. But of course, prevention is far better than treatment. So we have to make or to take some precautions before the surgery and during the surgery to prevent nerve injuries? The first thing is to understand the anatomy. When the surgeon knows anatomy very well, of course, he will be very careful. He will avoid making incisions in wrong places and avoid nerve injuries. The second thing, of course, to identify those patients who are more prone or having high risk to neurological complications, including those patients with thin body habitus, those with having ill-developed abdominal muscle walls or a narrow pelvis. And those patients are at further risk if the operation time will exceed 4 hours. So when you identify those patients at high risk, you will be more careful during your surgery to avoid nerve injury. The correct positioning of the self-retractor plates to cradle or to retract the rectus muscles without compressing the psoas muscles underneath. Because as we have seen in the anatomy, that most of the lumbosacral nerves are related to the psoas muscles. So you have to avoid compressing the psoas muscles during surgery to avoid the compression of such nerves. Try to use the shallowest retractor plate, which will provide to you the adequate exposure. Try to avoid the long and deep plates because it has been suggested that the degree of nerve injury is proportional to the blade length. The next point is try to undoing the retractors and repositioning at regular intervals. As I told you before, that when you use the handheld retractors, you can make like on and off placement of these retractors, unlike the self-retaining ones, which are doing compression for long time. So handheld retractors should be selected over the self-retaining ones, especially if we are having lengthy operation. The correct preoperative positioning of the patient. This is very important. Try to put the patient in the correct position, especially the lithotomy position. Try to avoid the hyperflexion of the thigh, the hyperabduction, and the external rotation. That's exaggerated position. Try to put the patient in the correct position with the stirrups or the boots should be at equal height. And also, don't forget to put a pad between the lateral fibular head and the stirrup, thus preventing the nerve compression against a hard surface. Avoid extending the incision beyond the lateral margin of the rectus muscle to avoid the entrapment of the ilioinguinal and iliohypogastric nerves, as mentioned before. The shoulder braces, if used during the steep Trendelenburg position, should be positioned over the acromioclavicular joint to prevent the brachial plexus injury. Don't put them too laterally to avoid traction on the brachial plexus. Just put them over the acromioclavicular joint, and the arm boards should be placed at an angle no further upwards than 90 degrees to avoid hyperabduction nerve injury. So by knowing the mechanism of nerve injuries, we can simply know the prevention or how to prevent. The last point to say that the nerve injuries may be a source of medical litigation. So we have to be very careful during the surgery because the doctor may be asked about the nerve injury and the maneuver done. So it is a cause of medical litigation, but fortunately it's ranked, the obstetrics and gynecology are ranked the 7th and the 9th place in cases of nerve damage. But of course, it's very important when you do operation to be very careful because this can have a medical legal issue. Before ending the today's session, let's practice some question. Which nerve is particularly susceptible to damage when self-retaining retractors are used in gynecological surgery? What do you think?
Femoral nerve. A.
Yes, of course, the right answer is A, femoral nerve. It's the most susceptible to be injured in gynecological surgery, especially by the self-retaining retractor. downward and inward muscle splitting incision from the McBurney point that allows extraperitoneal drain or extraperitoneal drainage of abscess is called? Yes.
Gridiron incisions.
Can you repeat your answer?
Gridiron incisions, sir.
Yes, gridiron incision. B is the correct answer, gridiron incision. Select the single most appropriate statement with reference to abdominal incisions and preoperative reparations in gynecological surgery. What is the correct answer here? Yes, I have correct answers in the chat. The correct answer is B. Preoperative showering with antiseptic reduces the infection rate to almost half. Of course, horizontal incisions cause more nerve damage than the vertical ones. The same scalpel can be used for superficial and deep incision. Vertical incision have worse cosmetic results and lesser strengths. And of course, wound infection rate are less if we make depilatory preparation rather than no hair removal. So all other options are wrong. The only correct one is P. Preoperative showering with antiseptic reduces the infection rate to almost half. This is an EMQ. Of course, EMQ type of question come for part 2. These are different nerves. Let's read each scenario and pick up the correct answer. Following a prolonged difficult hysterectomy for rectovaginal endometriosis, a 48-year-old woman makes a good post-operative recovery in hospital, although she did notice some altered sensation on the medial aspect of the thigh and cuff. When she returns home a few days later, she is unable to climb the stairs. Yes, exactly, as you are writing in the chat. The correct answer is B, the femoral nerve. That's the correct answer. The next. Following a sacrospinous fixation procedure, a woman returns to hospital with worsening gluteal and vulval pain. The pain is worse when she sits down.
Pudendal nerve, sir. Pudendal nerve, sir.
Yes, exactly. That's the pudendal nerve, the pudendal nerve. That's the correct answer. The last question. A woman with a body mass index of 38 is placed in the lithotomy position for planned vaginal hysterectomy. It's necessary to hyperflex and abduct her thighs in order to gain adequate access. Post-operatively, she has foot drop and has altered sensation on the lateral aspect of her cuff, dorsum of her foot. Of course, this is so obvious. As you correctly answered in the chat, it's the common peroneal nerve, the common peroneal nerve. That's correct. By this, we come to the end of today's webinar. I hope you enjoyed it. And I remind you again that we are starting our regular course for Part 1 MRCOG on the 15th of October. I wish you enjoyed this session. Thank you so much for your attendance. Of course, if you have any question, let me tell you also that this the recording of this webinar will be available on our channel on the YouTube. So if you want to listen again to this webinar, you can